Hello and welcome to our next episode of Clinical Conversations provided by the Royal College of Physicians, Edinburgh, Trainees and Members Committee. My name is Anda Bularga and I am a T&MC member. Today I am delighted to be joined by Dr Justin McKee, consultant in Medical Ophthalmology at the Princess Alexandra Eye Pavilion in NHS Lothian. Welcome Dr McKee and thank you very much for your time today.
Oh, thanks for having me.
So medical ophthalmology is a rapidly growing medical specialty that focuses on the vascular, inherited, infectious and autoimmune disorders affecting vision and other neuro-ophthalmic conditions. From important screening programs to investigation and management of chronic ophthalmic conditions and emergency cases, ophthalmology problems can be a primary or a secondary presentation of many acute and chronic illnesses. Today, we're going to discuss with Dr. McKee the most common systemic conditions that can present with eye involvement, and we are also going to find out about the work and the training of a medical ophthalmology specialist. So before we start, Dr. McKee, I just wanted to ask you to give us an overview of your daily work as a medical ophthalmologist.
Sure. So I spend most of my time doing outpatient clinics. So I do 3 clinics a week in uveitis. So the bulk of that is treating autoimmune ocular inflammation with immunosuppressive treatment, but I'll also see some infectious disease that can cause ocular inflammation. So conditions like toxoplasmosis and syphilis and TB. I do 2 neuro-ophthalmology clinics a week, one of which is in the Eye Pavilion, but one of which is in the Department of Clinical Neurosciences, which is a nice change of scene. I also do a thyroid eye disease clinic every week, and that's alongside my endocrinology colleagues, Nicola Zammit and Anna Dover, which is really kind of enjoyable multidisciplinary service to be involved in. And I also do one diabetic retinopathy clinic a week. So yeah, it's mainly sort of outpatient clinics and then associated administration, checking and investigations and so on.
That's quite a diverse weekly kind of job experience. And you mentioned quite a few of systemic illnesses. So I guess I'll continue by asking you, what are the main chronic systemic illnesses that are associated with eye or vision problems that you encounter in your day-to-day practice?
Diabetic eye disease is obviously a very common problem that we see a lot of. And I think we'll talk about that in a bit more detail later on. Thyroid eye disease, as I say, I do the thyroid eye clinic once a week. It's relatively rare, but it's very significant for the patients that have it. So, it's often young women who are coping with a change in their appearance, alongside, other symptoms that you can get from thyroid eye disease, like double vision, discomfort, and occasionally you can have sight-threatening manifestations like corneal exposure and dysthyroid optic neuropathy. So it's important to have a service that can, treat these patients appropriately. I'll often see a lot of patients with HLA-B27 associated disease, so patients with ankylosing spondylitis and inflammatory bowel disease, psoriasis and psoriatic arthritis. And these patients quite classically get an anterior uveitis, and they can get it sort of recurrently and can have it quite severely. I'll quite often see patients with multiple sclerosis and the sort of multiple sclerosis mimic condition, neuromyelitis ophthalmica, which can cause quite a devastating sort of optic neuropathy and transverse myelitis. So again, although it's quite rare, it's important to be aware of and to treat appropriately. We see patients with ocular myasthenia, but there's quite a lot of crossover between ocular and generalized myasthenia. Again, in neuro-ophthalmology, I'm not sure if it's quite a systemic condition, but we see a lot of patients with idiopathic intracranial hypertension. And even more so since lockdown, and a lot of people have gained weight over lockdown, and that's a condition that's associated with high body mass index. I see patients with rheumatoid arthritis, with sarcoids, tuberculosis. Got a few patients with Behçet's disease, which is obviously quite rare, but can cause quite a devastating and severe uveitis. And we also see, a few patients with ANCA-associated vasculitis, primarily granulomatous polyangiitis. So these patients can get scleritis. They can also sometimes get orbital granulomas. And what we've actually done in Edinburgh is set up a joint clinic with Dr. Bean Dawn, who's a nephrologist who runs the vasculitis service in Lothian. And we do that about every 6 weeks. And it's just really about trying to join up care for patients with these rare diseases who often see, multiple specialists. So yeah, we do see quite a lot of sort of systemic, multi-system disease.
What about hypertension, medical school, and then for kind of postgraduate exams, we learn about the manifestations of hypertensive eye disease. Do you see that, or is that less common now with, I guess, the improvement in the management of hypertension?
I think that it's probably less common than it was, before hypertension was so widely treated. And what's interesting about hypertensive retinopathy is that, there can be a wee bit of a disconnect between patients with retinal manifestations of hypertension and quite how bad their blood pressure is. So some of the patients we've had with hypertensive retinopathy, have had systolics that have been below 200, things like 180, 190 that might not necessarily make you panic on a medical ward, but, they can have not massively elevated blood pressures. I think really the best way to diagnose hypertensive retinopathy is to check the blood pressure, because diabetic retinopathy has quite varied manifestations. You can get disc swelling, so all patients that present with papilledema should get a blood pressure checked. And associated with that, you can get a sort of neuroretinitis type picture where you get these sort of streaky linear exudates coming in from the disc, towards the fovea. You can get things, that we learn about in medical school, like AV nipping and silver wiring and flame hemorrhages and cotton wool spots. We had a patient recently, you can get these rarer manifestations like choroidal infarcts. So the choroid is the layer of blood vessels between the sclera and the retina. In hypertension, because the sort of circulation dynamics there, you can get ischemia on the choroid, and you get these really sort of characteristic triangular wedge infarcts at the back of the eye. So as I say, there's a number of sort of different manifestations of hypertensive retinopathy, and it's just important for us in the eye clinic to remember to check the blood pressure.
Mm-hmm. And so we spoke, you said a bit about diabetic retinopathy. I guess this is one of the leading causes of loss of vision worldwide and a common diabetes complication. The screening programs that we have undoubtedly played an important role in the monitoring management of these patients. In your practice, can you give us an overview of the evolution of the national screening programs? And are they different in type 1 and type 2 diabetes patients?
In Scotland, we have a national screening programme. I think in the rest of the UK, it's run on a more local level. But we have a national screening programme in Scotland, and then it's sort of run by the different NHS boards. There's no difference really between screening for type 1 and type 2 diabetic. Every diabetic patient over the age of 12 is currently invited to annual screening. That involves a retinal photograph, which is done with or without, dilating drops with tropicamide. And we deliver it as locally as possible. So we've got like mobile cameras that go out to health centres and things like that. So the images are then graded, and there's 3 levels of grading. So level 1 grading is whether things are normal or not normal. And actually in Scotland, for about the last 10 years, we've used image analysis software, so an autograder, to analyse level 1 grading. It's continually quality assured and is shown to be quite a safe way of doing level 1 grading. After level 1 grading, if there are abnormalities, it will go to a level 2 grader, who's often a nurse or a medical photography or anyone who's been appropriately trained to level 2 grading. And if the image has moderate or non-severe, non-proliferative diabetic retinopathy, then the level 2 grader will decide whether they'll come in for a 6-month recall or go back to a 12-month recall. But if they think that there's severe non-proliferative diabetic retinopathy, so that could be features like venous beading or a lot of blot hemorrhages in the retina, then and they think that they've got referable retinopathy, or if there are new blood vessels, so proliferative retinopathy, which is also obviously referable, then the image goes to a level 3 grader, who's usually an ophthalmologist, and they'll get referred on to the eye clinic, or if they have proliferative retinopathy, they'll go straight into the laser clinic. I think in terms of evolution and developments of screening, so automated grading was quite a big development, and I think we're a bit ahead of the game in Scotland in terms of having implemented that. The other evolution that's happening at the moment is that it's been quite well proven that if somebody's had 2 annual screening episodes with no retinopathy, they can be considered at low risk for retinopathy. So their screening is being extended to 2 yearly instead of annual recall. And the other aspect of diabetic eye disease that we screen for is diabetic maculopathy. And that's when, because of prolonged hyperglycemia, you get damage to the capillary walls in the retina, and you get leakage of fluid. And if that edema is involving the fovea at the center of the macula, patients can get blurring of vision. So diabetic macular edema is a sort of three-dimensional feature. So on a photograph, you can only really look for clues. So for example, you could look for hard exudates, and that can be a sign that there might be macular edema. In the past, all these patients were referred into the eye clinic to be reviewed at a slit lamp by an ophthalmologist to see if there was macular edema or not. But actually, what we're now using in screening for these patients is optical coherence tomography, or OCT, which I think might also be used in cardiology. I'm not sure. And so basically it's an infrared beam that's used in a sort of analogous way to ultrasound, and it gives us this cross-sectional view of the retina. And using that, we can very confidently exclude or identify macular edema. And actually, that means that about 70 to 85% of these patients who were previously going to the eye clinic from retinal screening because of maculopathy can just stay in screening. And, that means that we can be much more efficient about who is coming from screening into the eye clinic, and that the patients that need treatment, can get it in a more, efficient manner, basically. And it, stops patients having unnecessary trips up to the eye clinic, which I don't know if you've ever been, but sometimes they can have quite a long wait in the waiting room, unfortunately. So I think they prefer not to go if they don't have to.
And just leading on to that, so changes in the screening program, what about the management? I mean, there's been some changes in the management of both type 1 and monitoring of type 1 and type 2 diabetes over the last decade. Have you noticed any changes in the prevalence of presentation of diabetic retinopathy? And also, what about the changes in the management of diabetic proliferative retinopathy?
Yeah, so I mean, one of the changes that's happened with diabetic management is patients going on to things like continuous glucose monitoring and insulin pumps. And one of our concerns when patients started going on to continuous glucose monitoring is that, we know from the very large diabetes control of complications trial in the early 90s that rapid tightening of glycemic control was associated with an early worsening of diabetic retinopathy before the long-term benefits of good control accrue. So we're always a bit concerned when patients very rapidly tighten their glycemic control. However, that's been looked at actually here in Edinburgh by Fraser Gibbs' team in the diabetes and endocrinology department, and they've actually published on this, and it's shown that with continuous glucose monitoring, reduction in A1C was not associated with worsening of retinopathy or associated with an increased risk of laser. So that was sort of reassuring from our point of view. And I think also it's quite a difficult message for patients. These are often patients that have struggled with their glycemic control over the years. And then you're saying to them, lower your blood glucose, but don't lower it too much. It can just be a little bit difficult to communicate that. Similarly, with insulin pumps, the same group have actually shown that in patients who are not under ophthalmology care for retinopathy, who go on to insulin pumps, there's no increase in retinopathy. But I know that the team in diabetes, when they start patients on insulin pumps, if they are known to have retinopathy, they will set slightly higher blood glucose, targets, just in order to avoid that rapid tightening. In type 2 diabetes, there's obviously a number of sort of agents that have been introduced in the last sort of decade or so to improve glycemic control. Semaglutide is one that has been associated, when it's combined with insulin, in fact, with an increase in retinopathy and need for laser treatment. So that's one that I think the diabetic team, in patients with retinopathy, they tend to avoid that combination of semaglutide and insulin. And the mechanism of that is not clear, but again, it's thought to be potentially due to this, rapid tightening of glycemic control. I think in terms of the treatment of retinopathy and maculopathy, there was a big change about 10 years or so ago with the introduction of injections of antivascular endothelial growth factor, anti-VEGF, intravitreal, so intraocular injections for diabetic macular edema. VEGF is kind of one of the main cytokines that the ischemic retina releases in diabetic retinopathy. And if you can blockade this, it's very effective in reducing diabetic macular edema and improving vision. These are the same injections that people might have heard of in age-related macular degeneration. And they're delivered by nurse injectors here at the Eye Pavilion, who do a really good job. Prior to this, all we had for diabetic macular edema was focal macular laser. And the aim of that was to maintain vision, but it didn't actually improve vision. And the other thing is that we were lasering quite near, the center of vision, so patients could develop, scotomas and so on as a result of that. So moving on to anti-VEGF treatment has improved the care of diabetic macular edema. And in fact, for patients who don't respond to anti-VEGF injections, we can actually give steroid implants, which in addition to blocking VEGF, block a number of cytokines and can sometimes, help in patients who've been resistant to anti-VEGF injections. For proliferative retinopathy, the mainstay of treatment remains laser panretinal photocoagulation. So in focal laser, I said we were lasering near the center of the eye, but in panretinal photocoagulation, it's the peripheral retina that we laser. We don't really know why it works, but I think of it in terms of, it's ablating the ischemic peripheral retina, and then that reduces sort of cytokine release and the drive for new blood vessels to grow. It is a good treatment and it's an effective treatment, but it's an ablative treatment. So patients can develop problems with peripheral vision. So for example, if a patient's had both eyes lasered, they need to inform the DVLA, and there is a risk that you could lose peripheral vision to the extent that you lose your driving license. We also use our peripheral vision quite a lot at night because that's where our sort of light sensitive rods are in the retina, and patients that have had laser will often report, worsening night vision. It's a bit complicated because patients with diabetic retinopathy, with proliferative retinopathy, they have an ischemic peripheral retina anyway. So they have, even without laser, they will have peripheral field defects. But I think, laser does worsen field defects. But actually now there's been a number of trials looking at the same injections I mentioned, anti-VEGF injections, treating proliferative retinopathy. And that's shown to be equivalent to panretinal photocoagulation, one big trial in America, and in fact superior to it in a UK trial that was done. The issue is that if you're injecting for proliferative retinopathy, once you stop injecting, within sort of up to 16 weeks, the proliferation will return because you've still got an ischemic retina. So in terms of implementing that in the NHS, it can often be difficult in the long term for diabetic patients can struggle to attend. They've often got multiple hospital appointments. And if there's a lack of continuation of that treatment, a patient could run into problems. Whereas with laser, once laser's been completed, that tends to lead to essentially lasting resolution of the proliferative retinopathy. I think that's probably coming soon for proliferative retinopathy injection treatment, but it's not yet implemented in the NHS, and there are, quite a few sort of considerations with it. But yeah, I think those are the main sort of changes that we've seen to diabetic retinopathy.
Thank you very much. That's a very good overview. Now, we discussed quite a lot about, chronic conditions, and I'd like to ask you a few questions about more of a kind of an acute presentation. Do you see patients in the emergency department or medical admission units? And what are the main emergency presenting complaints you encounter in ophthalmology?
Yeah, so if at all possible, we try to get patients to come to us in the eye department. And that's honestly not just because we're being lazy, it's because we can really assess them much better, if we see them at the slit lamp and so on. But sometimes that's just not possible. So for example, the trainees are not quite often, but occasionally have to go, for example, to intensive care. If a patient's been identified to have a candidemia sepsis, they quite often will ask us to come and have a look at the retina just to see if there is evidence of a sort of candidal endophthalmitis or these kind of things. For my part, my main dealings with medical inpatients are when I do my clinic at the Department of Clinical Neurology. So I'll often be asked to see neurology and neurosurgical inpatients, and that'll often be things like patients who are thought to have raised intracranial pressure, visual field defects, or optic nerve compression from a pituitary or a sellar or a skull base mass, or patients with double vision and nystagmus. These are the sorts of things that I'm asked to see, and I'll often be asked to advise or take over quite early on patients who come to our acute referral clinic in the eye department, who have, for example, a very severe uveitis that's causing a lot of pain or visual loss, or an atypical optic neuropathy. I think in terms of emergency presentations, one that there's quite a lot of crossover between medicine and ophthalmology is giant cell arteritis. which is, quite an important condition to identify. Usually if an ophthalmologist is involved in a patient with a giant cell arteritis, things are already quite severe. And the concern really is, if, for example, a patient's lost vision in one eye from an arteritic anterior ischemic optic neuropathy, which is the main mechanism, whereby giant cell arteritis can cause vision loss. If it's happened in one eye, it could very quickly happen in the other eye. So it's really important to identify if a patient has giant cell arteritis. The kind of blindness that you get from giant cell arteritis is unfortunately a very profound disabling blindness. So it's something we're desperate to avoid. Unfortunately, the more giant cell arteritis that I've seen over the years, the more I've come to appreciate that occasionally not all patients present with, dramatically raised inflammatory markers or very classical symptoms of jaw claudication and so on. So we really need to have a high index of suspicion. But on the other hand, these are often elderly patients who get very high doses of steroid for a long period of time. And that definitely has an associated, significant morbidity. And that's something that I'm also very keen to avoid. So temporal artery ultrasound has actually been a really helpful development in that, because we get a very quick turnaround from the ultrasound. And if it's positive, with a halo sign and the patient has a fitting clinical picture, then I would very rarely ask for a biopsy in that situation, because even if the biopsy is negative, you could say it was a skip lesion and so on. That's been a big help, and a negative ultrasound can also be very helpful, particularly in these sort of equivocal cases where you're just wanting to just rule out giant cell arteritis basically. And I think another good development in giant cell arteritis has been having a proven steroid sparing medication in the form of tocilizumab, and that's really helped to manage these patients and reduce steroid related morbidity, particularly if patients have recurrence of giant cell arteritis after their steroids have been weaned. The other urgent things that I would encounter are things like severe idiopathic intracranial hypertension or papilledema really of any cause, and remembering to do the blood pressure. And things like sight-threatening compressive lesions in the skull base. Third nerve palsies, I think, are quite an urgent thing to investigate, to rule out a PCOM aneurysm. And then, we'll also, urgent things I'd be involved in would be like, as I say, very severe uveitis cases that can be very vision threatening and require urgent treatment.
If you can give us a kind of a brief summary of what would be your approach to assessing someone who comes in with kind of an acute monocular visual loss or threatened vision.
So with monocular visual loss, I think really you want to know a little bit more about the presentation. So you'd want to know about the duration of the visual loss. So is it very sudden onset, like within seconds? And then you'd maybe be thinking along the lines of a central retinal artery occlusion. If it's gradually over hours or days, you might be thinking more of things like a central retinal vein occlusion or an anterior ischemic optic neuropathy, which, as I've said, can be arteritic in giant cell arteritis. But you can also get non-arteritic forms, which are unfortunately, again, poorly understood, but tend to happen in vasculopaths, so people with hypertension, people with increasing age. As I've said before, it's always important to think of giant cell arteritis, age, inflammatory markers, and then symptoms. And I would say kind of in that order, so if somebody has no symptoms, but they have raised inflammatory markers, you still want to really rule out giant cell arteritis unless there's another obvious cause for those raised inflammatory markers. You might think of optic neuritis, so that tends to be in younger patients. Classically, these patients will get pain on eye movement that often precedes the visual loss by a few days. And the loss of vision can present acutely, but actually, the patient will report it's gradually come on over a couple of weeks. It usually sort of gradually worsens over about 2 weeks in optic neuritis. So for retinal detachment, often patients will report like a shadow or a curtain coming in from the periphery of their vision. And again, in the history, there might be clues this is somebody at risk of a retinal detachment. So are they a high myope, or have they recently had cataract surgery, which can be a precipitant for retinal detachment? I'd want to know if there was pain or photophobia, and if they were a contact lens wearer. So I might be thinking of like a bacterial keratitis if that was the case. But I think most patients who present with persistent monocular visual loss, should be going pretty soon from the medical assessment unit to the on-call ophthalmologist or the acute referral clinic in ophthalmology. It might be in medicine that you'd more commonly see things like, transient unilateral visual loss. And of course, in that situation, you'd be thinking of amaurosis fugax, and those patients should be worked up by the stroke team. But again, Amaurosis fugax can be a presentation of giant cell arteritis, so it's important to satisfy yourself the patient doesn't have giant cell arteritis. And actually, what we see quite a lot is that it's important to pin down with the patient whether it actually was in one eye or was it an homonymous phenomenon that was in one half of the visual field, and the patient identified it as a monocular phenomenon. So I'm quite frequently going over, histories with patients and asking them, did you close one eye at a time? And sometimes they can be a little bit unsure about that, and you can start to figure out that actually it was a homonymous defect that they'd noticed. And a common thing that would cause that would be a migrainous aura. People commonly describe this sort of scintillating ring or kaleidoscope type visual phenomenon that starts in a small area of the visual field and then gradually, enlarges over the course of about 30 minutes. And it shouldn't last, for longer than an hour. And you can get, aura without headache. And as a general rule of thumb, sort of migrainous visual phenomenon will give you a positive scotoma. So you might see like a bright light or a kaleidoscopy type thing. Whereas a vascular occlusion will give you a negative phenomenon. So patients will report a blackness in their vision. So for amaurosis, they classically report a kind of black curtain coming down over their vision or a black transient visual impairment in one eye. So I think those are the main sort of conditions I would think about, the main approach I would take for a patient with monocular visual loss. Yeah.
Thank you very much. That's very, very helpful. Before the end of today's podcast, I wanted to ask you some questions about the training for medical ophthalmology and what training routes can you take for a career in medical ophthalmology?
Yeah, so trainees can come into ST3 in medical ophthalmology either from ST2 in internal medicine training, in which case they'll then spend the first 2 years of medical ophthalmology training, so years 3 and ST3 and 4, mostly in general ophthalmology training, and they'll do their part 1 FRC Opth. Or trainees can come from ST2 in ophthalmology specialist training, in which case they'll essentially follow IMT training for 2 years and complete their MRCP. I'd really sort of like to advertise the fact that we'll have 2 jobs in Scotland starting next year in August 2022. So they'll be in the recruitment for that round of jobs. 1 job in Glasgow and 1 in Edinburgh. So we'd really welcome, any potential applicants to get in touch.
Yeah. And so which route is more common, the internal medicine route or the ophthalmology special training?
Most years I'll be on the interview panel for medical ophthalmology, and it is actually pretty much, a kind of 50-50 split. I mean, one of the concepts that we talk about in medical ophthalmology is being bilingual, in that you understand the world of both medicine and ophthalmology. My own experience was that I came from what was then core medical training into ophthalmology, having heard a bit about the specialty and just been interested to do it. The eye clinic is quite a different world and there's a lot to learn, but it's very rewarding. But I think having that holistic and sort of systematic approach that we learn in medicine, is really valuable in applying to medical conditions that, that affect vision. But really, by the end of ST4, trainees from both routes are on the same footing, and have had, the same experience, but just in different order. And the other important thing to point out is that, the sort of medical aspect of training doesn't finish in ST4. So in sort of higher specialist training, ST5, 6, and 7, medical ophthalmology trainees will continue to have attachments in relevant medical specialties. So rheumatology, neurology, infectious disease, sexual health, nephrology, and so on, diabetes and endocrinology, alongside, going to sort of subspecialist ophthalmology clinics in uveitis and neuro-ophthalmology. So our experience is that by the time a trainee comes to their CCT, and unfortunately in the UK at the moment, there's only about 1 or 2 trainees a year that are CCTing in medical ophthalmology, they're generally, essentially headhunted by departments to come and work, because, there's an increasing workload, the increasing complexity of some of the treatments we're dealing with, particularly in immunosuppression. There's quite a lot of value in having a physician, dealing with that. And the other thing is that actually medical ophthalmology, as ophthalmologists, we're actually quite versatile. So being able to work to go from diabetic retinopathy to neuro-ophthalmology, Actually, in the world of ophthalmology, that's quite a stretch between subspecialties. So that kind of versatility is also quite valuable. So it's really a specialty where you see the most interesting patients in the hospital, and I think it's a really great career. So I'd encourage people to think about joining us.
Thank you. Yes, you did describe quite a lot of interesting interdisciplinary work. Thank you very much for your time and for all these very helpful insights on the common ocular manifestations of systemic illnesses, and for your overview of a career in medical ophthalmology. Thank you very much for joining me today.
Oh, thanks a lot.